your diagnosis, right? There's a patient with lower back pain, okay? Where do you start? Well, you start with, where's your pain? Describe your pain, or your symptoms, whatever they might be. Could be numbness and tingling, could be tightness, could be pain, could be dull, achy. I don't give a crap if it's dull, achy, or green. Like, I don't care. What I care about is, where is it? Because from there, what you're gonna do is you're gonna say, well, what's in that area? And this is neurology, right? This is the longitudinal level of the lesion, meaning, okay, if there's pain down here, well, let's assume that we understand there's joints, muscles, and bones down here, right? We know they are, but what is in the area? So what are some of the things that are in that area?
Start with the joints.
Lumbosacral joint, sacroiliac joint, facet joints of the lumbar spine oriented this way, right? And so then you have a hip joint, coxfemoral joint. So then you're like, okay, there's some joints. You get a pubic symphysis in there, right? But from here, your tailbone, your sacrum can go like this or like this. And from here, these guys do this, and these guys move a lot. Now, in order to function properly, they have to do that. If someone has pain in that area, even with a disc injury, it happens because it's from limited mobility. So joints should move. When they don't, when they get stuck, that's when they create pain. Muscles tighten around them to try to compensate and move, because we still have to move and bend and do things. So muscles have to do extra work to try to facilitate movement with those limited joint mobility, with that limited joint mobility. When they do that, they get tight and they get hypertonic and they swell and they create inflammation, and that irritates nerves. Now, if you have limited mobility long enough, or pressure on a disc long enough, it can create a herniation, and then you're going to be getting subsequent, numbness and tingling, or pain down a leg, usually, and those sorts of things. So you start in the area of their complaint, and you expand outwards. Okay, you start right here. You say, well, I have pain across the back. You're like, okay, I'm going to start with those lumbosacral joints, that lumbosacral joint, the SI joints, and the lumbar facets. A lot of times what happens is either the sacrum is stiff or limited mobility, it's not moving, or this is shifted and this is shifted, they're stuck and rotated, and the lumbar spine on the contralateral side is restricted potentially, creating like a counter rotation. We know they don't really rotate, but we know they kind of do this limited mobility aspect, where now they are, good for me? Thanks. So here you get this kind of counter rotation, like you're squeezing a washcloth, right? And you squeeze it, it doesn't come out each side, it comes out the middle. So if somebody says, I have pain right in the middle of my back, a lot of times it's because these things are rotated. People call them misaligned. It's not really how it works, because we know joints don't really shift out of place, but they just become stuck where they can't go this way, if that makes sense. They're not pushed back, but they can't go forward, or they can't go backwards. So that's really important. From there, then we can expand. So we're like, okay, we've assessed this area. It's kind of like if your like kid got lost in the woods, right? How you would create like a system of like checking, like, this row, what do you call it? Not a gradient, but like like you'd break it up into little parcels. A grid system, thank you. So like you grid this out, and then you're like, oh, I want to check the coxfemoral joint. You're like, okay, I'm gonna move a little lower. I want to check the hamstrings. Well, maybe I want to see like what that knee and ankle are doing for mobility. Because if that ankle is really stiff, then I wonder if every time they step, they're putting a lot of pressure, and this is absorbing more kinetic force than we really need, than it really should. And so those muscles get tight and that joint gets more restricted because it has to do more work. And then you say, okay, so I've assessed the grid of the lower body. I've assessed the nerves. There's nothing, the reflexes are kind of normal. There's no limited sensation or hypersensitivity, hyposensitivity or hypersensitivity in the lower extremity. There's none of that. So we're like, okay, we're kind of good. And then we start working our way up. And then we start getting into like, I wonder if there's a QL issue here. I wonder if these ribs are restricted and they're not breathing properly, so they're angling themselves differently and they're breathing upwards and they're changing the integration of the muscles and the joints of the lower pelvis, the lower spine. Now I'm not starting there because I don't want to miss the obvious issue, but these things could be contributing. And then you get into posture, right? Which is correct. Posture can contribute to this. You got somebody, who's called center of pressure. If they're anterior center of pressure, if they're leaning forward and they're kind of doing this and they're doing this, absolutely that can contribute. But that's probably not the, acute cause of their pain. It might be the chronic contributor, so it's really important to look at that. So that's another, what we call longitudinal level of the lesion, meaning who in this process, we look at the nerves, joints, muscles, and brain, could be involved. Now, if you have limited mobility in the joints, what happens to the muscles? Well, they get tighter because they're trying to pull. That creates pain inflammation. It can create nerve irritation. Well, what happens to the sensors in our joints called receptors? Well, they get stimulated less and less and less. So now that brain's main feedback, main communicator, the receptor, is now not telling the brain information. And so the brain can't really, it changes the mapping in the brain. So the brain can't really coordinate and control this because it's not getting good information in about what's going on here. So it can't coordinate it very well outwards or facilitate healing or whatever it might be. And it says, okay, now I have to compensate. So if the map for this area is this big in the brain, when it can't understand what's going on there, what it does is it enlarges the map. It expands the map. So then it says, okay, if you're not going to give me information here, I got to get information like from a bigger area to like kind of just compensate for that. And so then this person says, no, now I'm getting pain up here. Now I'm getting pain, and now I'm getting pain in my hamstrings are tight. Now my quads are tight, my hip flexors and all these things, because the brain's starting to tighten everything up to get a bigger amount of general information, but less specificity. And we know in neurology and in chiropractic especially that specificity is key. So the brain has to coordinate this and get good information from it in order to understand how to affect it. So then you say, okay, now you've got the joints that are limited and they're not moving. Now the pain nerves are reaching the brain faster than the proprioceptive nerves. Remember that term from school, proprioception? So proprioception is just receptor stimulation from the joints and muscles to the brain. And they are larger nerves. They're 1A and B afferents. So they're really fast. They're highly myelinated, thickly myelinated, so they're super fast. Now, pain nerves are always parallel to these proprioceptive nerves, but they're slower. They're unmyelinated, the type C nerves. So they're very slow. They're sluggish. And that's a good thing because that allows proprioception to win. And proprioception tells the brain, oh, there's no pain here. This is moving fine, we're good. But when it gets slow, now it can no longer inhibit the pain. And it does it through collateral inhibitory pathways, but it also allows pain to reach the brain first. Because now, pain being slower usually, the tortoise, if you will, and the hare, somebody shot the hare, so now the tortoise wins. Doesn't matter, it takes longer, it still gets there. So now, the patient starts to experience pain instead of movement in receptor stimulation of proprioceptive nerves. So now what happens is it remaps for pain. So now this person comes in who's had this for 2, 4 months, 3 years, 6 years. Their brain remaps and they actually use the pain nerves to understand more about what's going on in that joint and in the muscles. So the brain rewires itself for pain. So now when they move and they function, everything is painful because you limited the proprioception feedback from the joints and muscles. So you say, okay, well, how do we change that? Well, great question, because what we do is we figure out where the problem is specifically, and we start to gain mobility. We start to gain movement. And when we gain movement, we activate these little receptors of sensors, starts to stimulate, ping more proprioceptive information in the brain. And we do that, and it says, well, the habit of pain is so strong, like, man, it's hard to beat that. How do we beat that? Well, you beat it by doing the right thing repetitively. And so if you do a high frequency plan with a comprehensive treatment style, which is muscle, joint, nerve, and brain, then, Zach, if you give me 1 second.
So I was just letting you ace reviews also.
Yeah. So you've got pain in, sorry, I forgot where I was at. What was I saying? So you've got proprioception now.
You're talking about
starting-
like frequency.
The frequency,
of
right, okay, thank you.
Thanks.
So you've got the frequency, and we do a comprehensive plan where we affect the joints, muscles, nerves, and all of those things. So what happens is you start to give a little more momentum to the proprioception by doing a very comprehensive approach and a high frequency approach, which then starts to it's like here's the habit. 1 time a week, 2 times a week, 3 times a week. Okay, you start to get a change at 3 times a week, 4 times a week, 5 times a week. So this is where people often miss the boat, is people might be doing the right thing, but they're not doing it enough.
Yeah.
And so they're treating it from as if the body just exists by itself. But it doesn't. It exists with the brain. Or an integration of the two. You can't really separate them. So where chiropractic neurology comes in. Is now we're looking at it from, oh wow, well, if the brain is changed, and that's what's really controlling this, I actually have to treat the brain. So to treat the brain, I have to use a high frequency comprehensive plan to shift the mapping of the brain, which then kind of takes this thing from eventually like this, and shifts it back and says, okay, now that I have the good information, we can get rid of pain, because that's not, now we're getting fast, good information that's inhibiting pain. Pain is now got the brakes on it again. And it all happens because you start with a good diagnosis. So you figure out where their problem is, and then you expand out. It doesn't really matter what they have going on. It does, but it doesn't, if that makes sense. I do care if it's, numbness or tingling or down their leg, that's different, right? Because that's more where. What caused it, I care a little bit, but I don't care as much as what and where. What is it and where is it is the most important thing. Then those other things are important, but they're not, you gotta start there, and then figure out in this whole aspect, where could it be? That's the longitudinal level of the lesion. That's neurology. That's it.
Awesome.